Hello and welcome to Building Healthy Connections. I'm your host, Berthine Crèvecoeur West. Welcome to our final episode for 2016. Here we've created a space where we can talk about language, culture, diversity, and healthcare. So let's continue building these healthy connections in 2017. Thanks so much to everyone that's tuned into our podcast and for reading our blog. Today's episode is going to be dedicated to our providers. We're going to be discussing patient culture, but a specific part of patient culture. We're going to be talking about what people think brings about illness. So with regard to that, well, I should be more specific. We're going to talk about how culture impacts the way people think about illness. And that is really, I'd like to start out by reading you guys a quote. And it's by a renowned anthropologist named Edward T. Hall. And this is what Mr. Hall says. People from different cultures not only speak different languages, but what is possibly more important, inhabit different sensory worlds. Experience, therefore, cannot be counted on as a stable point of reference because it occurs in a setting that has been molded differently in each culture. Now, what is Mr. Hall saying when he's referring to that? Essentially, he's saying that our experiences cannot be a singular thing or viewed as one point of reference because the manner in which those experiences are perceived is based upon our culture. So basically, he's talking about a cultural lens. So when something happens to me, let's say we have two experiences. Well, we have one experience and two different people experience that same experience, right? It might be seen as a completely different experience because of the way our cultural lens has been shaped, right? So let's take something as simple as going to the doctor. Now, my experience has been that I've been predominantly raised here. And so having been born and raised here, I will go to the doctor and expect to see 4 people in that entire appointment. So that would be once you walk into a facility, you would see the intake clerk. And they would, well, first let's start with the receptionist. You'd see the receptionist. Then you'd wait for a few moments. You'd see the intake clerk who would take down some vital information about you and give you perhaps an identification number if you're going in for a procedure. Then you would see the nurse, and the nurse would discuss certain things with you and ask you about advanced directives and a living will and all of those sorts of things and take some family history from you. Then you would see the doctor performing that procedure. So those are 4 people that you would see. Now that's my experience through my cultural lens of being here in America, where this is a typical thing to go through. However, let's say that I was born and raised in another country where that process doesn't exist. So when I would come here and go through it, I might perceive that same experience that the American had, the native born American had, as a completely different set of circumstances. I might be intimidated by it. I might find it fearful. If there is a linguistic challenge for me, then I might have to use an interpreter, which is a 5th provider, if you will. So this same experience would be altered by sheer virtue of my not having been exposed to this on a cultural level in the home country, if that makes sense to you guys. So we can both have the same exact experience, but it'll mean different things because of that cultural lens. So now let's get to what do we think, why do we think, or better yet, let's get to how culture impacts the way we perceive and deal with illness. So most people, I think the world over, they believe that when they get sick, there are reasons why they get sick, right? So let's explore some of those reasons. In the biomedical culture of the United States, meaning how providers are trained specifically in the United States, there are clinical reasons why people get sick. So let's take the common cold. You'll get a cold from a virus and you'll be prescribed some medication. If that cold leads to something else, like a respiratory infection, you'll be prescribed perhaps some antibiotics and you'll be sent home where you have to lay down and recuperate. Now, let's say I'm a layperson, right? A regular average Joe. And so what might I do when I get a cold? I'll tell you what I do. I tend to take some medication that's over the counter. I tend to have some soup, get some rest, and in a few days, I'm back to my natural self. However, not everybody does this way. I can tell you that my mother didn't do that, and she was born and raised in a different country. So she used to think that I got sick if I left the house with wet hair, or if I left the house with my coat open. And that's not to say that that's wrong at all, because culturally, as she grew up, if your hair was wet and you happened to catch a cold, well, then those two things go together, right? And then what I've come to find during just my experiences in the world is that everyone, regardless of what culture and what country you come from, has a soup as a curative measure. So, everybody's grandmother has a soup. Americans have chicken soup, and other people have different types of soups. I know growing up, there was this soup my mother used to make that was made out of bread and vegetables and pasta, and I did not like it, and I always had to have it to cure a cold. And I tell you, it was not fun for me. But culturally, that's one of those things that just was a part of my growing up, eating that soup when I was sick. So now whenever I do see that soup, I dislike it even more because I know it's associated with me having a cold, right? But there are other soups that people make. And in addition to soups, there are teas. Particularly amongst my Asian friends, everyone has a tea for something. A grandparent has a tea that will help. And that serves as a curative measure. But let's backtrack a little bit to what people think causes illness. So we discussed why providers in the biomedical culture would think that it's something clinical. It's got to be a virus that causes an illness. But in certain cultures, sometimes it's the lack of ancestral worship that causes that. So if you come from a culture that worships your ancestors, such as the Cambodian culture, one of the reasons you may perceive an illness is because one of the reasons you may think that you have an illness is because you might not have worshipped your ancestors in the appropriate manner. And then you feel that they're coming back and making you ill is a way for them to gently remind you did not stick to the cultural practice that we have, and you have to do that. So that can be a reason why people perceive illness. Another reason is some people will think that how would you say this? It's bad luck or mal de ojo. So that's another translation for that is the evil eye. So some people might think that you might have done something wrong and it's coming back to revisit you. That's why you're getting sick. Another reason could easily be a religious reason. Perhaps you feel that you've done something in your life that was contrary to your religious beliefs, and you feel that God is punishing you for this. We've had patients in the hospital, LEPs and non-LEPs, believe that this is the reason why they got ill. Now, when we hear all of these reasons, there's one more thing we should mention. Susto is also very popular in Latin American culture as a reason for an illness. And susto is basically a shock you receive from a traumatic experience. So one example is there were two workers, and one worker saw another fall out of a tree and die during the course of their day while he was working. And then the other worker who was unharmed, he developed a severe pain in his back that extended from his back to his leg. Now, he thinks that was because of susto. So whatever that shock of seeing his coworker die kind of transferred itself into him, and that made him sick. Now, could that be something psychosomatic? Yes. Could it also be something similar to sciatica? Yes. But the very important thing here is to remember that as a provider, we want to welcome LEPs and their beliefs as to what causes illness. This is a very important thing to do because we always want to be respectful. And providers are subject to do no harm as well. So by by adhering to that ethic that they have, that code of ethic, it's important that they acknowledge, understand, and respect the LEP's belief system. They don't have to believe in it themselves, but they do have to acknowledge, respect, and understand it. The same thing that interpreters have to do. And only interpreters would serve an additional purpose by being a cultural broker and explaining to the provider why the LEP believes that they are ill. So a good example would be when a provider says to you, well, what brings you here today? Right? The LEP would render that interpretation by asking, why are you here today? And then the interpreter would render that interpretation by asking the LEP, why are you here today? The LEP would then explain, if it was the case of susto that we were discussing, the LEP would mention, well, I'm here because I'm in pain and this is the reason and this is why I think I'm here. So the interpreter, being accurate, and professional and adhering to the code of ethics, would have to render this interpretation and be that cultural broker. And then once you put that information into the arms of the provider, they can then understand the perspective from which the LEP is coming. So do you see how it's really important to have culture play a part in the communication between the provider and the LEP? You need that cultural broker because the provider is not expected to understand the LEP's culture. They might have never even heard of this, but it's real and it is important and it's necessary for us to convey that information as their interpreter. So that's an example of how culture plays a part in people's thinking what might make them sick. But then when we're thinking about what might make you sick, well, culture also plays a part in curative measures. So what makes you feel better? So again, we mentioned a soup, a tea. There's a practice in the Asian culture called cupping. Cupping is used to, you take a heated cup and you put it on the skin and until it raises welts. Now, the purpose of cupping is to draw out the impurities, draw out the illness, and it's practiced by millions of people. However, if that provider is not familiar with cupping, they might see it, and this has happened before, they might call a social worker because a mother was performing cupping on her child, and they might think that is a sign of abuse. That's why it's very important to have an interpreter serve as your cultural broker. So for my providers out there, always, always, always make use of your healthcare interpreter. They are your partner in helping your patient have the best healthcare outcomes possible and really forging a true and genuine relationship and understanding between the both of you. So once, let's say, the healthcare interpreter explains to the provider what cupping is, that's going to help so very much because then the provider will be operating from a place of knowledge that they might not have had before. All right. So let's also be very aware that when we do interpreters, when we serve as a cultural broker, it's very important for us to avoid stereotypes. Now, I'll give you a quick definition of stereotypes. It's a preconceived notion or standardized just description about an idea about the alleged essential nature of those making up a whole category of persons. So essentially, that's just applying one belief to a particular group by using terms such as always. So I will take Haitian culture into consideration for this example. I will say Haitian people are always Catholic. That is not true. You may meet millions of Haitian Catholics, but that doesn't necessarily mean that all Haitians are Catholic. So we have to be careful with stereotypes when we're talking about health and culture and diversity. So in order for us to serve as a cultural broker, we would have to use terms such as generally or usually or a predominant amount of Haitian people are Catholic. So you could say many, many Haitian people are Catholic. So that's one way to avoid a stereotype, but to have a generalization. Mm-hmm. So let's backtrack a little bit some more and talk about some additional curative measures. These might be seen as alternative with regard to the U.S. biomedical culture. But you will often find that curative measures that may be considered alternative are quite common for the LEP. So we want the providers to be aware that what might be considered alternative for the biomedical culture here, American providers, might be considered everyday practice for many of our LEPs. Some of these would be cupping, as I mentioned before, shamanism, acupuncture, massage, therapeutic touch, Reiki, for instance, reflexology, guided meditation is also something that people use. Ointments, deep breathing exercises, there's Qigong, there's Tui Na therapy, there's herbalism. There's so many different therapies out there that people can use and that they do use in their everyday practices at home. So after having explored what we think makes us ill from a variety of cultures, the goal in this is to acknowledge that both things can coexist. So basically, providers can prescribe, they can diagnose and then prescribe what they think will help the LEP recover from this illness. And they should also, once they've learned what the LEP's cultural practice are with regard to curative measures for illness, they can also recommend that LEP seek that therapy as well. So let's say I have an acupuncturist and my provider gave me a prescription. Ideally, we want the LEP to follow the provider's prescription, but also feel free to practice their cultural belief and go to an acupuncturist. This is how you can ensure the best healthcare outcome and really facilitate that wonderful relationship between the provider and the LEP. And this is, again, bringing up the code of ethic of respect and professionalism and cultural competency. So as I mentioned in previous podcasts, these things go hand in hand. So it's really great when interpreters are used in the most effective way possible, because we are a tool to help our providers be their very best and to keep our LEPs in the best health possible. So that's going to basically wrap up what we've been discussing with regard to patient culture. Now, stay tuned for our episodes in 2017, where we'll be discussing culture in detail. And we thank you for continuing to send in all of your questions. We love seeing you guys reach out to us on our webpage and follow us through our social channels, our social media channels. Please continue to read our blog. We're going to post much more information in greater detail. So again, thank you so much for tuning into these episodes, these podcasts that we've created to discuss language, culture, and diversity and healthcare. So we look forward in 2017 to bringing you much more of this type of content. And now we'd like to take a moment to thank our sponsors, the West Linguistic Training Group, LLC, and One Voice Medical Interpreters for making this podcast possible. If you'd like to find out how you can be a part of this podcast, please feel free to contact us. You can reach us at www.buildhealthyconnections.com.